Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. It's been more than 2 decades since the ACR released general treatment guidelines for systemic lupus, and a lot has changed. Today, I'm joined by Dr. Lisa Sammaritano as we dive deep into the soon-to-be published 2025 ACR Guideline for the treatment of systemic lupus erythematosus. These guidelines reflect not just the evolution of therapeutic options, but a broader shift in how we approach lupus, emphasizing patient engagement, minimizing steroid toxicity, and tailoring care across diverse organ systems and age groups. We'll explore what's new, what's changed, and what clinicians need to know to bring these recommendations into practice. Dr. Lisa Sammaritano is professor of clinical medicine at Weill Cornell Medicine and an attending physician at the Hospital for Special Surgery. Her clinical and research work focuses especially on pregnancy and reproductive health in patients with rheumatic diseases. You might recognize her from an episode in 2020 where she discussed the reproductive health guidelines, which she led. In 2022, we invited her to talk about hot topics in reproductive health. And in 2024, she discussed the ACR 2024 Lupus Nephritis Guidelines, which she also led. You might say she's the ACR Guideline Queen. And she told me that in crafting guidelines for the ACR, she's really found her jam. And you can tell from her excitement when she discusses the guidelines that it's really true. Enjoy. Lisa, welcome to the show.
Thank you. It's a pleasure to be back.
So we're going to be taking a look at the new ACR 2025 Lupus Guidelines. And I was trying to look back at when the last time the ACR published just general lupus guidelines, and it was in 1999. I was still in college. That was a long time ago. Lisa, can you explain a little bit what took so long to develop these lupus guidelines?
I think there were a number of factors. For one thing, lupus therapies really didn't change very much in the early years of that lag period. And I think in more recent years, thankfully, we've had a number of new therapies approved. So that, of course, always pushes you towards updating a guideline. In the 1999 guideline, the recommendations for serious lupus were high-dose steroids and cyclophosphamide or azathioprine. And it remained that way for a while. Mycophenolate, of course, came into play. But now we have many more options, thankfully. So I think that's one important factor. The other factor is that it took, once I think the ACR realized, yes, it's absolutely time for a revision, I think it was hard to pull together a team. It's just, you have to have the right people at the right time, many of whom cannot have conflicts of interest, because that's a very important part of our structure for our ACR guidelines, that we have a majority of participants who don't have conflicts of interest. And, it just took time to pull everyone together. And I think now that we managed to get through nephritis and general lupus in a 2-year period, I guess, with much of that work overlapping. So we're really pleased that this is almost ready for publication.
It's awesome. And, by this time, I think you're like an expert at writing, these ACR guidelines. You've joined us before to discuss the reproductive health guidelines a couple of years ago. Last year, we talked about the new lupus nephritis guidelines. And now you're leading, this team of just general lupus guidelines. Tell us a little bit about sort of the process of writing guidelines and why you've stuck with this for so long.
Well, so the process has, of course, evolved over the years. And now, at least since 2015, maybe 2012. The ACR uses grade methodology, which is a really rigorous method for development of guidelines. And I already mentioned one important component of that, which is that the majority of the participants have to have no conflicts of interest. So they can't be involved with pharmaceutical companies that are producing some of the therapies. And so that's felt to be important. And all of the conflicts of interest are, posted and easily available for those who do have that. The other thing is that there is a separation of the core team who is making up the so-called PICO questions, which I'll come back to in a second, and the voting panels, so that in this way you can look at the scope of what you'd like to cover, make sure the whole team is in agreement. We write up what are called PICO questions. It's just a very specific way of asking a question: population, intervention, comparator, outcome. And by doing that, it allows our librarian and the literature review team to look at the evidence for each specific question. And there are hundreds of iterations, depending on the medication, the specific symptom, the specific comparator. Once that literature is pulled in the systematic literature review, there's a lit review team entirely separate from the voting panel who goes through. Everything is reviewed by two sets of people. They find the relevant literature and they grade it so that we understand, yes, this was a, double-blind randomized controlled trial versus a case series,
Hmm.
and that makes a huge difference in how much weight one gives to the evidence. And then finally, we take that evidence, the core team sort of inverts those questions to be suggested recommendations for monitoring, treatment, et cetera, and we present those to the voting panel. And for this particular guideline, because there were so many areas that we wanted to cover, it was actually a 3-day, 9-hour-a-day
Wow.
process for voting, because it's not just voting, of course. The lit review and the level of evidence is one part, and it's a very important part. But on top of that, you have experts' interpretation of that evidence. And also, especially when the evidence is so limited, as it really was for many of our PICO questions, you want to know what these experts do in their own practice, because our goal is to give guidance. We don't feel it's very helpful to say, well, there's no randomized controlled trial for that. Sorry, we can't comment. We really want this to be useful. And so there was a lot of, at times, spirited discussion about which medications were better, which should come first. That was also an important question. And, once you see, I think, the full manuscript, you'll appreciate that we often did not make a specific recommendation for one specific treatment, both because the evidence didn't support it at this point in time, the experts didn't support it with their clinical practice, and the patients didn't support it, because it became apparent to us that patients really have very strong views about certain medications for themselves. And we had a 13-person patient panel that spent a number of hours going over their views and preferences with 3 of our team participants, physicians. And, some of them really have strong feelings about certain medications. And if one doesn't take that into account, you risk losing that person, right? If you give a patient one option for medication and it's one they don't feel is right for them, that's not very helpful either. So I think that is the process. And that whole process took about 2 years
Wow.
from start to finish, and we're now near the finish line. And we just hope that, even though there aren't a lot of very specific recommendations, we hope that we, have put through some important guiding principles to help people in thinking about treatment, and then give them particulars for both treatment of lupus as a whole and for certain organ systems, how to think about it, what the options are, and then, of course, emphasizing to discuss it with the patients.
These guidelines were, somewhat unique in that you meant them to apply to both children and adults with lupus. I'm wondering a little bit about the composition of the teams. You mentioned that patients were involved. Can you talk a little bit about who else was involved in making these recommendations?
Yeah, so on our core team, which is the team that makes up the PICOs, writes the manuscript, organizes all of the input from the various sources, we had two pediatric rheumatologists and a team of 8 or 9. We also had a dermatologist,
Hmm.
which was very helpful because I feel like cutaneous lupus is an area that rheumatologists could learn more about. you know, is
True.
not every patient can be sent to a dermatologist to have that one symptom managed. And then on the guideline team as a whole, we had other pediatric rheumatologists, we had other dermatologists, mostly rheumatologists. We had a PA, so we had I think a broad spectrum of specialists. And importantly, so that we could try to present some of the information that might not always come across. So many of the recommendations are just for patients in general, but we do have a section where pediatric rheumatologists emphasize the important principles of caring for children in terms especially of corticosteroid use. We have a table with suggested drug dosing for adults and for children. And again, that's not a part of our recommendations. It's like a supplementary table that we think is something that might be useful when you're reading these recommendations. You can remind yourself about the dose or the monitoring and things like that. So again, we tried to provide some supportive suggestions, that kind of material as well in the manuscript that will, I think, add to a clinician's ability to actually use these recommendations.
Yeah. And, from what I've read, you in the guidelines, you mentioned the importance of shared decision making and sort of re emphasize that throughout the various different statements. Can you talk a little bit about, how you recommend that physicians manage this, when, we're all busy and it takes time to have these discussions with patients? How should we take that into account?
Yeah, and I agree with your point about it taking time, but I think a little time at the outset is worth it in the long run. And so, yes, it may take time, and maybe you even schedule a separate appointment with someone to go
Mm,
over the options. Sometimes I'll just have a telemedicine visit with someone to go over all of the therapy options so that they understand what's available, they understand which I recommend, they understand the side effects, and then they can tell me what's appropriate for them. This is not the main point of shared decision. The main point of shared decision making is to encourage a good relationship, a sense of trust, to express our respect for the patient and their views, their priorities, what they think and what they want. But a beneficial offshoot is that if you go through this, it is more likely that these patients will be happier about taking the medication. And if there are issues with adherence, I think they'll be less likely to happen if you put the time in ahead of time to understand where they're coming from. We had two patients on the voting panel from the patient panel, and that was great because when we talked about these different medications, one patient said, well, I have a lot of friends who developed depression with belimumab. Well, that's important information for us to have. We know that this is a potential side effect, but this particular, individual was recounting something that she had heard that obviously is going to impact one's willingness to enter into that therapy. So we just tried to really listen and then in our day-to-day practice, hope that most clinicians can either set aside time, schedule another appointment, at least give the patient the options, and then delve into detail as appropriate.
Yeah, I think that's one of the things that I noted about these guidelines is sort of a menu of appropriate recommendations of treatment options for, various for the various manifestations of lupus. That, oftentimes it's not just like you must use this one drug. It's like these are the drugs that are available, and from our perspective, they're all sort of equally beneficial. And I guess that makes it easier for, having those discussions with patients where, this menu is, we feel like it's sort of has equal benefits, and we can discuss with the patients which medications they think would be best for themselves or for their children. Another thing I noticed about the guidelines is sort of this push to minimize glucocorticoid use and try to, maybe even introduce immunosuppression earlier rather than just use corticosteroids. What do you think drove this shift to make this happen and, to trying to reduce glucocorticoids and do immunosuppression a little bit earlier?
I think this is a natural evolution in terms of treatment for any disease or disorder, that you start out with looking for something that works. And then once you find something that works, you try to fine tune it and pick the best protocol or the best drug or the best way of giving a drug. And I think that is a natural evolution that is happening in lupus, in most of our rheumatology disorders, and it's reflected in all of our ACR guidelines as well as international guidelines on lupus and other diseases. So the evidence for really the toxicity of glucocorticoids just keeps accumulating. And we see it in our practice, in our patients, but there's a lot of literature that supports even significant, morbidity with low dose steroids. And to me, that was actually an interesting and somewhat surprising fact that I learned as I was doing this, that, 5 milligrams a day of prednisone is just not harmless. It's sometimes what we will do. And, again, patient discussion, you make a decision, but it's not harmless. And so I think clinicians just need to recognize that. And I think patients do as well, because they don't see the side effects immediately the way they might if they take 60 of prednisone and they can't sleep and they gain weight. But, low dose steroid for a long time does have significant, morbidity associated with it. So that was behind the push. And one of our strong recommendations, and we've really made very few strong recommendations because, that suggests almost everybody should do this, as opposed to conditional recommendations where we say, consider this, it may not be right for every single person. So one of the strong recommendations was to get down to 5 milligrams or less by 6 months when treating a patient with lupus. But then we made some conditional recommendations. Try to get off if you can, taper slowly over time. And so again, that's conditional. And that was a point of a lot of discussion with the voting panel. I am sure you, as I have seen, have patients who are happy on a low dose of prednisone, and they really do not want to take a so-called immunosuppressive medication because they can't get off prednisone. And I think, that's a quality of life issue. It's a patient preference issue. All we can do is educate ourselves and the patients about what the risks and benefits of the various options are. But I think that there are still many patients who would rather take that low dose than consider starting on mycophenolate, for example. I think the other thing that has made it hard for us to taper off glucocorticoid is that when you try, people do have steroid withdrawal symptoms. And, lupus is a disorder that often has fatigue and generalized achiness, and those are the symptoms they will get. There's concern about adrenal insufficiency, rightly so, you know? So I think those things also keep us from trying it. But I think, if you try in a half a milligram or milligram at a time over a long period, it's often worthwhile. Some patients are eager to try and some are not. But the thought should be there. At least it should be discussed.
That's one of the, I've said this on the show probably several times. One of my mentors, sort of got me to ask for every patient that's on chronic steroids, what happens when you taper? And
Mhm.
the issue is that for many patients, they never even try, right? They're
Yeah.
stuck on 5 milligrams of
Yeah.
prednisone. So I love these recommendations of like, try to taper. And as you mentioned, there's no rush, do it slowly. And I like, this conditional recommendations of escalating immunosuppression if you're unable to taper. Because,
Mhm.
we think, as you mentioned, maybe over long periods of time, being on a little bit of mycophenolate may be less toxic than being on chronic steroids. So I'm a fan of that. The other thing I noted about the guidelines is that for patients on remission, you know, there's support for tapering steroids and immunosuppression. How should clinicians think about that? When do we say that the patients are in remission? And how should we think about de escalating therapy?
Yeah, great question. I think we could not give specific guidance on that because we really appreciate that there's tremendous variability as well as, emerging evidence, but not necessarily specific evidence, for example, with a treat to target protocol, as we are getting used to using for rheumatoid arthritis. And, those studies I think are in progress. And I think for revisions of this guideline, we may be able to be more specific. But we really see the goal of our treatment as being either remission, not remission off medication, because that is rare and hard to find, but remission on low dose or no steroid and some dose of immunosuppressive as well as hydroxychloroquine. But if not that, because that also can be hard to get to, then a low level of disease activity, because there is a lot of evidence that tells us that even if you're not truly in what we would call a remission, having a low level of disease activity is a good thing and it
Mm.
protects you against accrual of damage over the years. So, how to decide who and when? And I think this is where patient discussion comes into play. It's where knowing a patient's history and their preferences and the severity of their prior manifestations also comes into play.
Mm.
So I think when someone is either in remission or has a low level of disease activity after some period of time, and we say 3 to 5 years, I think it's reasonable to be tapering their medication if they're on board with that. And if you do it in a reasonably slow way, because that's the only way you can know. And it does seem a little bit like trial and error, but patients vary so much in their response to medications and their response to withdrawal of medications that I think slow is safest for everyone. So it's not easy, but I do take all these different factors into account. If someone nearly died from severe life threatening lupus, I will probably treat them for longer and I will probably withdraw medication much more slowly and more carefully. All those factors are important.
Yeah, it makes a lot of sense. And I have to highlight that while the guidelines recommend in people that are in remission, try to taper the steroids and the immunosuppression, they also have a strong recommendations for continuing hydroxychloroquine indefinitely, even in those patients with remission.
Yeah. Well, I will say the strong recommendation is for being on hydroxychloroquine,
Oh, for being there.
everyone, if there is not a contraindication. The indefinite course is actually a conditional
Mm.
recommendation. And that's because we just don't know. And, there is a study in progress now looking at discontinuing hydroxychloroquine in older and very stable lupus patients. So we may have more information again with our next revision, but that indefinite continuation is conditional. And the other conditional recommendation about hydroxychloroquine was in reference to the dosing, because that's a controversial area too. Should it be 5 milligrams per kilogram, as in the most recent ophthalmology, recommendations? Or should you go back to 6.5 milligrams per kilogram? Because maybe for our patients, that's what works. And we ended up trying to consolidate all those different views, look at the data, and we ended up saying aim for 5 milligrams per kilogram. But you may need a higher dose for periods of time. And so that was our way of acknowledging the facts, but also aiming for the least, retinal or other toxicity that we can. We did not comment on measuring levels of hydroxychloroquine because we didn't feel we had enough evidence to guide us one way or the other at this time.
Great. And, the guidelines also provide a lot of recommendations in regards to like neuropsychiatric lupus and hematologic manifestations. It's so great. Just a couple of weeks ago, I was talking with one of my fellows. We had a lupus patient that had significant lymphopenia. And we really didn't know what to do with that. Should we treat it? Should we not treat it? I like the guidelines here. It says for asymptomatic neutropenia and or lymphopenia, you recommend against immunosuppressive treatment. So you provide a lot of recommendations in regards to both the hematologic and neuropsychiatric lupus. Was there anything that surprised you, or sort of any medications that you thought were interesting to include in the treatment of these complications?
So, I think for neuropsychiatric lupus, there wasn't anything surprising to me, right? I mean, we all turn automatically, I think, to it's a bad organ system to have involved. And I think we automatically turn to what we think of as our strongest therapy, which is cyclophosphamide. So that wasn't so surprising. What surprised me, I guess, was the limited evidence that exists to support that. And that went for all of our organ manifestations, really always a low or very low level of evidence. So, two things, not great evidence regarding those specific organ systems. And for some of them, heme, for example, we extrapolated from the hematology recommendations because we thought it's better to do that than, again, say, well, we don't know. So we did try to extrapolate, even though the patient groups were different. And then the other thing was that, and it comes back to this sort of recommending a number of different therapies, both for overall lupus and for many manifestations. And that's because there are very few head-to-head or comparative trials. And so we just can't say whether one particular therapy or class of therapy is better on its own than another. Most of our studies involved the addition of a therapy to standard therapy. And obviously, there's good reason for that. But it doesn't answer the question, should I start with this therapy or should I start with that therapy? And so that was frustrating. And I think led to a lot of discussion and led to, again, these rather broad recommendations. Hopefully, over time, there will be more information to help guide us in choosing what actually might be the most beneficial. But we'll see. So for now, we know they all work. And it does give us the ability to be flexible and to engage our patients with that and allow them, to give us their input about what they would choose.
Lisa, you mentioned before that, rheumatologists aren't very comfortable or familiar with the cutaneous manifestations. And I really appreciate all, the recommendations about treating, acute, subacute chronic cutaneous lupus, bullous lupus, chilblain, leukocytoclastic vasculitis. Your dermatologist must have been very busy in crafting all of those guidelines. Anything new in the management of skin disease in lupus patients?
So I can tell you that I think a couple of things drove us to be so specific with the cutaneous lupus manifestations. And the first point is that there are so many of them. And so, while we group together subacute and acute just because of the way the evidence has been, developed, it's not the same as bullous, and it's not the same as leukocytoclastic vasculitis, and it's not the same as chilblains. And we just thought it would be useful to give, groups of medications that are best for these different subsets of cutaneous lupus. We're dealing with every organ system of the body, essentially. And I think we are, of course, quite used to collaborating with other specialists, whether hematologists, nephrologists, dermatologists. But there are some simpler things that perhaps we can help our patients with without necessarily referring them to a medical dermatologist. So, for example, and there are things that are more commonly done in dermatology than in rheumatology. So one example is considering adding quinacrine to hydroxychloroquine. It's an issue because, of course, it has to be compounded now, and the
Mm-hmm.
cost of that can be quite variable, apparently. But adding quinacrine to hydroxychloroquine sometimes can save you from having to start an immunosuppressive. So it's something to at least be aware of, even if you don't do it. For chilblains, adding pentoxifylline
Hmm.
can be helpful. That was new to me. I didn't realize
Yes.
that. I have since been doing that. so so I'm an example of how we can still learn, to incorporate some simple things that might make certain symptoms better for our patients. And I would say the new thing in dermatology is that dermatologists love anifrolumab.
Hmm.
So they are really, from the various dermatologists on the guideline team, they're really using it a lot. And that is their clinical experience, but there is some evidence that, it really works quickly and it works well for most forms of cutaneous lupus. Now, should you use that before other things? No, we don't say that. But when considering a biologic, that is a very good one to consider because of the really good response that they've seen.
Yeah, many of the recommendations, talk about the possibility of using biologics for care. And yet at the same time, you acknowledge that there may be some disparities in the access of care,
Mhm.
right? How do you think these recommendations could be applied in resource limited settings? I wonder if you think about these guidelines as to pertaining like the US population, but I imagine that, people from all over the world will also be looking at these guidelines to try to get some idea of how to treat, their patients with lupus in places that have even fewer resources than we do.
Yeah, we did. It was targeted to the US population, but with an awareness, of course, of, international issues. Not that we don't have the issues here in the US as well. So I think there's a couple of different kinds of limitations in terms of access. And the one that we are probably most frustrated by, of course, is when insurance coverage will not cover a particular medication that we think is appropriate. So I think that in that way, we have tried to suggest spectrum of therapies that will absolutely vary in terms of cost and may be available to individuals even without insurance.
Hmm.
A generic medication may be inexpensive, conventional immunosuppressive. So that's one way we think it can be useful. Another way is that we are hoping that by putting out these guidelines and talking about the benefits of particular medications, it may over time increase use and perhaps persuade insurance companies that these are beneficial. We have shown it based on this evidence, and, it should be covered. And then the other way I think it increases access to care is that, this guideline is written for the practicing clinician, not necessarily someone who is in a tertiary care, medical center, has access to a million specialists at the, touch of a button or through with an epic chat. But I think that we want to make these recommendations available to a rheumatologist who is practicing in a rural setting, perhaps, where they don't see that many patients with lupus. And so this way, they have all the latest evidence and, the experts' guidance on what to do. And I think that's an access issue too. So patients don't have to travel. They can go to their rheumatologist, and their rheumatologist has access to this information. So I think that's an important benefit as well.
Yeah, and you're totally right. Many of the medications that you describe are not FDA approved for the indications that you say, like, what drug is approved for bullous lupus or for chilblains? I don't think any drug is, right? So,
Right.
often when we get pushback from insurance companies, I always like to say, well, I realize it's not FDA approved, but ACR 2025 guidelines for the treatment of lupus does recommend the use of X, for this treatment. And sometimes that can provide support for the benefit of using these medications in patients, even though they may not be FDA approved. Are there any concerns that you have when rheumatologists are using these guidelines? Are there concerns that, they may misinterpret your recommendations or oversimplify the management of patients with lupus that, as you and I and everybody knows, some of these patients can get very sick very quickly?
Well, I think that it is important to recognize, of course, the limitations of any guideline document, because you cannot possibly cover every specific situation. So it's important to appreciate when you have a patient that doesn't fit into
Mm.
we try and address, the most common issues or the most serious issues, but we can't possibly address every single potential complication, especially for lupus. But I think the other important thing to remember is that out of all of the recommendations that we make, only 3 are strong. And strong recommendations are the ones that, pretty much everyone really should follow. And those strong recommendations are: use hydroxychloroquine if you can, decrease the glucocorticoid to 5 or less by 6 months, and introduce immunosuppressives early to allow taper of the steroid. So all of the others are conditional, and that means it isn't saying you don't have to think. It's saying, look, this is what we think is reasonable for most patients in this situation. But think about your patient, think about their potential risks and benefits, and discuss it with them. And I think that as long as people take that seriously, I'm not worried about an oversimplification.
Lisa, and you mentioned that many of these recommendations were given with fairly low level evidence. Budding researchers in the years to come and fellows that are interested in research projects, what do you think are the biggest unanswered questions in lupus that can provide some evidence, from which, these guidelines could benefit in the future?
Well, I think there are sort of 2 categories of areas of future research. One is to do head-to-head studies so that we really do know, for a patient with arthritis and lupus and no other manifestations, should you treat them with a biologic right off the bat, or should you give them methotrexate? We don't have a study that can answer that. There's just very little that looks at our medications in a comparative way. So I think that kind of trial is really, really important. For example, there was a study that came out I think it was 2017, that did compare mycophenolate to azathioprine, not for renal lupus, which, of course, is well established that mycophenolate is better, but for non-renal lupus. And mycophenolate is better for non-renal lupus with a quicker time to response and a better rate of response. So we do mention that within the text of the guideline that, we would prefer mycophenolate. Azathioprine has its place, especially someone of reproductive age who, can't take a teratogen. But we need more studies like that, both for lupus activity overall and also for, specific organ systems. So that's one huge unmet need. And then the other, I think, is there are so many specific issues within lupus where we don't have enough evidence. One example, cognitive dysfunction. We actually addressed that with a recommendation because we have, as rheumatologists, we've all had the discussion whether or not someone with cognitive dysfunction in the absence of other neuropsychiatric manifestations should be treated with immunosuppression. We made a conditional recommendation against that because there's just not evidence to support it. And again, because the experience and views of the voting panel members also did not support that. There are other medicines that are being studied for cognitive dysfunction in lupus, and, that may help us with future recommendations, but that's an example. Small fiber neuropathy, Jacquard's. Should we be sending these patients to orthopedic surgeons to have their MCPs replaced? I mean, personally, I think not, because every time I've seen patients who've done that, it just comes back worse. But we actually had a PICO question about that to try to answer it. We found one retrospective case series review that basically said, there's so many different surgeries and so much variation, we don't know. So we weren't able to make a recommendation for that. But I think even that is useful because you don't want someone assuming that you should be sending them to the orthopedist. And I think patients want that fixed. So it's good to be able to say, we just don't have data that supports that. It's a personal decision. Your hands will look better for some years, but not necessarily a good long-term outcome.
Mhm.
So that kind of thing, many questions like that could benefit from, some targeted studies.
Lisa, you've led many of the ACR guidelines. We talked about the current lupus guidelines, the lupus nephritis guidelines, the reproductive health guidelines. I wonder what you've learned from leading these various groups and what you would recommend others that are also working on guidelines. What are some of the things that make you particularly good or effective at this job?
Well, I think it is challenging in a particular way, and that is one has to be open to many different points of view, has to look at evidence with a careful eye. I actually have joked with the team members that I think that somehow I am good at this because I am a middle child. Because I am so used to trying to make peace and keep everything, in a good place. Really, diplomacy is important because you have to respect everyone's viewpoint, but at the same time, you have to get to a conclusion. You have to reach an agreement. And so I think that that's the challenge of this, but I really have enjoyed it so much. I've learned so much from all of the guideline team members, and I would encourage rheumatologists to participate in a guideline, whether you are a fellow or a junior, attending. To do the literature review is incredibly educational. And then, at some later point to be a part of the voting panel, incredibly educational. And you feel like you are giving back to the rheumatology community. I appreciate all of the guidelines that I look at, and I refer to them often because we're at a point now in medicine where we can't just say, well, I'll look that up and see what the literature says about it. There's just too much literature. There's too much to do. So to have someone else do it for you is incredibly helpful. So that's what we're trying to do. We're trying to be helpful, and we're trying to come up with a useful document that will make rheumatologists' lives a bit easier.
I wonder if you used any artificial intelligence device for the generation of the guidelines or for research, and if not, whether that's something that, you discuss or you would consider using going forward.
The only artificial intelligence was that one of our core team members used it to consolidate our voting panel discussion transcript.
Hmm.
But other than that, no, we did not. Although I know that that is being discussed. I've even seen publications debating this. So I'm not sure. I would have to learn more about what's possible before I would consider it.
Great. One last question. When are the guidelines going to come out, or where are we expecting them to be published?
So they will be published. I can say that now because they've been accepted.
Amazing.
We
Congratulations.
are, thank you.
It would be
We are
awful
in,
after 2 years of them being rejected. My goodness.
yes. Yes, that really would. But we're just in the midst of making some sort of minor revisions over the next few weeks, and then we'll be sending the revised manuscript back to Arthritis and Rheumatology and Arthritis Care and Research because they'll be published in both.
Great.
So I would think within a few months it should be coming out.
Great. So once you have an accepted manuscript, please send it over to us and we'll include it in the show notes so that everybody listening can have access to them. Lisa, this has been an awesome conversation. You've really brought these guidelines to life. It's super interesting to hear your experiences about, how these guidelines were put together and sort of the big goal of, as you mentioned, helping rheumatologists manage patients and providing patients with sort of a menu of acceptable options. I think that was great, and you've done a great job. Certainly, I will use this going forward in treating my patients with lupus, and I hope other listeners, I have no doubt that other listeners will do so as well. So thanks again for all your hard work.
Oh, thank you.
Well, there you have it, the 2025 Guideline for the Management of Systemic Lupus. This episode reminded me that while lupus remains a complex and heterogeneous disease, our approach to managing it has really evolved, rooted in better evidence, more options, and a deeper understanding of patient priorities. I think it's worth re-emphasizing the 3 strong recommendations that were proposed in the guidelines, which include tapering steroids, using hydroxychloroquine, and escalating immunosuppressive therapy in patients with ongoing lupus disease activity. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, don't forget to ask, what happens when you taper your steroids? And of course, stay healthy.